Good morning, everyone. How are you guys doing out there this month? Everybody having a good start to their summer? Good. Good. Okay. So today, the plan is to go more in detail with the CDC guidelines and specifically go behind why the CDC made the recommendations that they did. To start off, though, does anybody have a case that they would like to present to the group that we could go over?
Case, questions.
Case, questions. Anybody have a good story about any patients they've interacted with after, with the ongoing situation that we have with Dr. Rand or anything? Anybody see any of his patients and have some feedback? Okay. With that being said, what we can do is we can start the presentation, and what we can do is at any point if anybody has any questions or clarifications or need anything, don't hesitate to stop me and speak up, and we can discuss the slides in detail. Okay. I got it right here, correct? Yeah. All right, so we're going to discuss the CDC guidelines, part one. My contact information, if anybody has any questions afterwards, please don't hesitate to reach out to me. I'm always available. And we've already kind of talked about 2 months ago about how, is this an American epidemic or is it just hype? And I think we've shown clearly that since the change in paradigms in the 1990s, in the early 2000s, those changes have led to increased opioid sales. And if you look at the curve above that, it shows that opioid deaths had followed the exact same curve. So that had led to a time for change, in which the CDC now has come out and posted guidelines in March of 2016 on giving advice to physicians on how to prescribe opiates for chronic non-cancer pain. The target audience that they're trying to reach to is family practice, general practice, or internal medicine. They saw a trend between 2007 and 2012 that those areas had increased their prescriptions of opiates, while other specialties had not, and that greater than 50% of all opioid prescriptions generate from primary care physicians. These guidelines are meant to provide recommendations to the primary care providers who are prescribing opiates for chronic pain outside of cancer treatment, palliative care, and end-of-life care. The recommendations break down into 3 areas of consideration. Number 1 is what we're going to cover today, and that's determining when to initiate or continue opiates for chronic pain. The second consideration is opioid selection, dosage, duration, follow-up, and discontinuation, which we'll discuss on a future date. And 3, assessing risk, addressing harms of opioid use, we'll address in the future as well. Any questions on these recommendations and how they break down before we get going? Okay, so the first recommendation that the CDC made was basically they recommend that non-pharmacological therapy and non-opioid pharmacological therapy are preferred for chronic pain. Providers should only consider adding opioid therapy if expected benefits for both pain and function are anticipated to outweigh the risks to the patient. The reasoning behind this, what the CDC states, is that basically there is no medical literature or evidence out there that exists showing that long-term opioid therapy provides sustained pain relief, functional improvement, or quality of life to patients. But there is evidence out there that shows that non-pharmacological therapies can help chronic pain, specifically physical therapy, weight loss for patients with back pain or knee pain, spinal manipulation, acupuncture, massage, psychological services such as cognitive behavioral therapy, interventional procedures, and they do clarify that only certain interventional procedures can help chronic pain. The problem with these therapies can be the cost and time to the patient. Anybody want to weigh in on patients and their compliance to physical therapy? Who here thinks that when you recommend physical therapy that all patients are compliant and go to it? I would tell you my personal experience with physical therapy is that a lot of patients who are especially working will tell you that they cannot find the time to get off work, nor will their employer let them get off work to follow through with physical therapy. The second complaint I hear is that they're unable to afford their $40 copay to do it twice a week. Anybody hear these same complaints? Yeah. Mm-hmm. So that's a common thing. The other problem, if you look at the list, spinal manipulation, acupuncture, and massage, typically aren't covered benefits under most insurance plans. So you can recommend those things, but insurance may or may not cover it for the patient, and then the patient is stuck trying to pay the balance or pay the bill to follow through with those therapies. And then psychological services, I'm seeing that a lot of insurances don't cover cognitive behavioral therapy. Any comment on that one?
Yes, it's certainly a challenging benefit to get. We need to have a lot of justification for that, which is in the literature. So we can definitely come back and say, hey, it's been shown empirically to actually help people with chronic pain, but it's still often a struggle. And then there's another dimension to that too, and that is that many people with chronic pain feel that it's physical in nature, and therefore to be sent to somebody in mental health somehow implies that it's in their head and not real. So frequently we struggle with that in terms of having people actually make that appointment and come to it because their pain's real. It's not in my head. So a number of challenges, I'm sure, to all of these components in terms of trying to implement them into a pain management program.
Do you ever have patients who get referred to you who have insurance, but their insurance doesn't cover it? How often will you see that they will pay out of pocket?
Well, again, it's just like you were suggesting with the $40 copay for PT, times can be tight, and so and psychological services historically have not been covered at the same rate, so the deductible oftentimes was higher. With I think some of the changes in the insurance world, we're supposed to be on parity with medical treatment, but it's still money out of their pocket to come in for services.
And I do see a big push lately in the media that they're trying to say that they're trying to get psychological services more as a covered benefit. Have you seen any of that change in your practice where it's easier, or you've seen a difference where an existing patient, they get better coverage, or is that still being tossed around there and hasn't actually occurred?
I've seen an improvement in the situation, certainly from 10 years ago. However, it still is an out-of-pocket expense, even with the deductible. So it's been a challenge. And the other part of that is, because of that, many of my colleagues don't take certain insurance companies. So it's very common to get a referral from a pain management doc, and the provider's not on that insurance panel, so everything then becomes out of pocket.
Correct. The other thing that I've seen is Medicaid. Mm-hmm. Medicaid, if you can get the services provided, the patient doesn't pay anything. Mm-hmm. But from what we've experienced in our practice with our social worker is the amount of paperwork that has to be submitted to Medicaid to get the services covered. Yeah, is that?
Certainly, yeah. You need pre-authorization to even do a pre-screening test. So I've seen the paperwork be a huge obstacle again for that referral.
And if I've looked at that paperwork, and I think it's about 10 to 15 pages long, and it has to be filled out prior to even seeing the patient to get authorization. So I think there's some barriers that need to, or some walls that need to be taken down in order to allow us to better treat our patients, isn't it?
Absolutely, no question. And insurance is an obstacle for sure.
Anybody have any comments about insurance obstacles, or want to go over a case that they have and maybe try to discuss how to get around the obstacle? I got a question. Besides insurances being an obstacle to get patients for treatment, I've got a question I want to throw out there, and I want to get everybody's opinion on it. Just show of hands, who here is an employee of a large organization or works for a clinic where they're an employee? One. Okay. And then who here owns their own clinic and makes their own decisions? My question is if you're working for an organization, are they currently using patient satisfaction scores to determine your pay or bonuses to your pay?
They will be.
The community for, or what is it, the complex care, do you guys, do they do patient satisfaction scores at your facility and put it as part of your reimbursement?
Hey, can you hear me?
Yeah, I can hear you.
So we do not do satisfaction surveys. We had a temporary satisfaction survey. We had a social work student here, but no, we haven't been doing that. However, there are talks with in the leadership right now with creating a satisfaction survey. We do have resistance though, because we have so much paperwork that the patients fill out. In that brief time that we did have the surveys, the patients were not happy about it.
Okay. Are you guys involved with leadership on how the satisfaction scores should be put together? Do you guys have some say in that?
Yeah, we do, but again, we haven't really broached the topic too much. We've just kind of mentioned it as of the last couple of weeks, so it's kind of on the back burner right now. Okay.
And I know CMS is trying to go to a patient satisfaction-driven model, where if the patient is happy, then your reimbursement is higher. Have you guys heard about this?
Yeah, I've heard something about it. That was part of the conversation we had.
Okay. So there was a physician I met who is in California and works for Kaiser, and he would cover the urgent care clinics for them. And what he was telling me is that their quarterly bonuses are determined on a formula that includes patient satisfaction. What he found last year is that one quarter, when they sat him down, he got bad satisfaction scores because he was unwilling to prescribe opiates to patients who did not need them coming through the urgent care. Because of that, administration didn't pay him his quarterly bonus, and moving forward, he told me that any patient who came to the urgent care, he would give them whatever drug they wanted to make sure he got high satisfaction scores in order to get his quarterly bonus. So I tell you, this is a problematic system, and if you guys can be involved with administration and given those scenarios, you probably want to make sure that your future compensation isn't going to be tied into doing what is medically appropriate versus what is patient appropriate. Does that make sense? They recently had an article published out of Case Western / Cleveland Clinic regarding this issue. And I think at a higher level, not only at our local level with local facilities, should be aware of this, but probably CMS needs to address it as well too. If the CDC is going to come out and tell us that we should consider other alternatives for chronic pain, then they should probably incentivize us to do that and not punish us if we get bad satisfaction scores from patients for not prescribing them opiates. Okay. Any other questions about any of these alternative therapies?
If I could make a comment, it is ironic that the insurance companies will often deny treatment for some of these additional services for that very reason, that it's too costly or that somehow it's not going to make a difference, when in fact we have data that suggests it does.
Correct.
So there needs to be some changes at that level, I think also.
Anybody here take Amerigroup? Don't you feel with that insurance that you're like a dog chasing your tail? I'll see their patients all the time, and I'll recommend, first appointment, I'll say, hey, let's do physical therapy. And, when I see the patient, back a month later, they'll have gotten their pain medications, no problem, but the physical therapy will be denied. Have you seen that? Usually after the physical therapy's been denied, then I will say, okay, well, if they're going to deny physical therapy, why don't we try this injection or intervention to help out? And then the next denial I'll get when I see the patient back in a month will be that they haven't failed physical therapy, so therefore I can't do the procedure. And it's back to square one. And then I'll recommend physical therapy again, and usually even get denied a second time, and then I'll have to set up a peer-to-peer process where I have to get on the phone with their medical director and advocate on the patient's behalf on why physical therapy is important. It's unbelievable to me, though. In the meantime, you think that they would at least deny the chronic opiate therapy. Wouldn't that do us a favor if they would deny that and approve the other services? So it would be good if the insurances actually would kind of step in and make certain changes. One, maybe make the medications more expensive, that patients come back in and say they are unaffordable, but yet the physical therapy is affordable. There definitely needs to be some changes in paradigms at the insurance level to help the providers out.
Can you see this question?
Sure. There's a question here.
From Peggy Nicholson in Jackpot.
I cannot read it.
It says, what about patients with degenerative disc disease or spinal stenosis? Besides weight loss, what can be done?
So, well, first things first is degenerative disc disease is a tough diagnosis to make. Sometimes a dark-looking disc on MRI may be natural degeneration, or it could be early disc disease, but may be asymptomatic. The only way to confirm that a dark disc on MRI is causing a patient pain is to do a discogram. Discograms are very controversial because there's not a lot of evidence to say that a provocative discogram is a true sign that is actually causing a symptom pain, because a discogram is a very painful procedure to go through. So I'd be careful on one, labeling somebody with degenerative disc disease. That may be just an MRI finding that is asymptomatic. And what's the second part of the question? What else can be done?
What can be done?
Well, one, these patients, it comes down to I always go through 5 things that I can do for patients. So the first thing would be modality. So for this patient, could a TENS unit benefit their back pain? Absolutely. You may want to look to see if they can get insurance coverage for a TENS unit. Now, is a TENS unit going to cure them? No. Second thing is medications. And that could be different medications from over-the-counter, Tylenol and anti-inflammatories, to prescription medications, muscle relaxants, anticonvulsants, and then lastly, opiates if needed. That would be my last resort. The next thing you can do for them is send them to physical therapy. A physical therapist may be able to put them in flexion biased or extension biased exercises that can alleviate their pain, and basically it'd be by trial and error with the physical therapist to make sure that they can get the pain relief they need. The next thing that you can do is certain interventions. So, I mean, in your office, you could try trigger points to see if that alleviates some of their pain and improves their function. Two, a pain specialist could even do an epidural if it's truly discogenic pain to alleviate their pain. Or lastly, you may want to try blocking the facet joints to see if that's what's causing their pain versus the disc. And you could do facet joint cortisone injections. And then lastly, if they fail everything, maybe a surgical consult to see if there's any surgical intervention that could alleviate the patient's pain. Does that answer your question?
Just further question. Okay, but talking about megasymptomatic with multiple back surgeries, also spinal fractures, what non-pharm therapies are useful?
Non-pharmacological therapies are useful. In that situation, I think it's going to be trial and error. I don't think there is a right answer to that. One, with these types of patients, usually if it's axial back pain, I'll probably try some topical medications, get them lidoderm patches to put over their areas of pain. Maybe even try Voltaren or Pennsaid gels for them to apply 4 times a day over the area. If they're not on any medication, sometimes I'll go to scheduled Tylenol, 2 in the morning, 2 at night, around the clock, no matter what. I'll have them try that for 4 or 5 days, and if that is helping, I'll have them continue it. If it is not, I'll have them discontinue it. Anti-inflammatories, you got to be careful of those because they can cause GI bleeds, high blood pressure, and even some cardiovascular risk factors long term. Usually I tell patients that they can take 800 milligrams up to 3 times a day as needed. But I try to tell them to do that more on a random basis, not on a continued basis due to the risk factors I just listed off. Next, I would look at trying different types of muscle relaxants to see if they can alleviate pain, and maybe even an anticonvulsant like Neurontin. Start at a low dose and titrate it up to see if it can get relief.
And if I could add, I would imagine a patient like this would probably be frustrated with the fact that they still have pain and maybe angry and even depressed. So in terms of the model, adding other modalities, including behavioral medicine or what I call psychology services, would be appropriate to kind of add another member to the team to see if we could kind of help with the mood-related emotional pain tied to the physical and the frustration.
Krista asked for clarification on modalities.
Oh, modalities are any, they're like ice, heat, TENS units. That's what modalities are. And a TENS unit's a transcutaneous electrical neuromodulation device. Basically, it's electrical pads that the patient can put over any painful areas, and they can turn it on and control it. Modalities aren't going to cure anybody. They're just something that can give a patient temporary relief, hopefully to avoid them from having to take an oral medication or get them through a bout or a situation.
TENS units are extremely cheap now.
Exactly.
I got one for $30 on Amazon.
Correct. Very, very inexpensive. Any other questions out there? If you back up to that patient who's had multiple back surgeries, they're probably at their end of the rope, and that individual may be a perfect situation for them to see a pain physician. There's 2 different interventions that may help out. One, spinal cord stimulation may be able to help alleviate their pain and get them off opiate medications. The second thing that's coming out now is intrathecal drug therapy doing microdoses. And we're talking about doses so low that the adverse events that occurred with pumps in the past are completely eliminated. And we're talking about that's less than 1 milligram a day being dispensed into the intrathecal space. There's case reports out of the University of Kentucky that patients, if they get weaned off their pain medications or off them for 2 to 3 weeks, do a microdose drug pump, and if it's positive, have it implanted. They're showing that patients can be on 250 micrograms of intrathecal morphine or hydromorphone up to 2 years with an 80% or 90% improvement of their pain. The good news about that is in the past, when you get a pump refill, there's chances of filling the pocket, not the pump, which can leave the patient susceptible to overdose. Well, in these situations, if they fill the pocket, not the pump, it's just like going to the ER and getting a Dilaudid shot by an ER physician. There is no chance of overdose.
Will insurance cover a pump?
Absolutely. Insurance is definitely covered, will definitely cover intrathecal pain pumps. The hard part about the intrathecal pain pumps is convincing the patient that they have to be weaned off all their opioids for a 2 to 4 and be off them completely for a 2 to 4 week period before you do the trial. That is a hard sell and can take time. Most patients that we convince to do that, usually it takes at least 6 months of convincing before the patient's willing to give it a try. And that may be a time for CBT therapy as well to help the patient through that process, especially when they're weaning off. It can be a very difficult and stressing situation for the patient. Any other questions? All right. The CDC also reasoned that several non-opioid pharmacological therapies are effective for chronic pain, and we've already kind of listed these off: the acetaminophen, NSAIDs, antidepressants, and anticonvulsants. And what they pointed out is that these drugs are not associated with any drug dependence, not leaving your patient at risk for a opioid-dependent disorder. So bottom line, given that uncertain benefits and substantial risks, opioids should not be considered first-line or routine therapy for chronic pain. Anybody have questions on this first recommendation? Perfect. Moving on to the second recommendation from the CDC. They basically said that before starting opioid therapy for chronic pain, providers should establish treatment goals with all patients, including realistic goals for pain and function. Providers should not initiate opioid therapy without consideration on how therapy will be discontinued if unsuccessful. Providers should continue opioid therapy only if there is clinical, meaningful improvement in pain and function that outweighs the risk to patient safety. So the reasoning behind this is basically the CDC points out once again that there is no data to state that long-term use of opiates will help provide patients with pain relief, improve function, or quality of life. But typically what they've seen is that providers typically write prescriptions for 30-day increments. So when you see a patient, it's a fine line between when you're initiating versus continuing long-term opioid therapy. A lot of times we adopt these patients from other clinicians, correct? So they come to us, they were previously seen somewhere else, they're on, let's hypothetically say 2 Percocet a day. They show up, they talk to you about their other health problems, and then at the end of the appointment, hey doc, what about my 2 Percocet a day? A lot of times we end up, writing for that and trying to refer them to pain management or someone else. Invariably, they end up showing up 30 days later for a refill, correct? So CDC states that, knows that that's a typical situation that we have. And they define that an opioid prescription for 30 days represents an initiation or a continuation of long-term opioid therapy. So even though we may be thinking we're doing a bridge script for this individual, they're pointing out that to them, that represents that we are initiating or continuing a long-term opioid therapy program for this patient. And they say that prior to writing this prescription, that providers should establish treatment goals. And the goal should include both pain relief and function. And what they also state is that clinical meaningful improvement has been defined as 30% improvement in these scores. So that's nice that they're defining what clinical improvement is. So 30%, a lot of us would probably think that they'd expect 50% or better, but they say 30% is adequate. Bottom line, they state that the clinical evidence did not reveal studies that evaluate the effectiveness of written agreements of treatment plans. So even though they're advocating that we advocate putting a treatment plan together, there is no literature out there that states that these actually work. But they said that this is, puts the expectations out there on how the opioids will be prescribed and monitored so that you and the patient are on the same page. And I find that out that a lot of times patient satisfaction, usually will be determined on, what was put in place from the get-go. That a lot of times, if patients felt blindsided, they're unhappy.
Yeah.
And basically, they want you to spell out opioids will be tapered or discontinued if treatment goals are not met, if opiates are no longer needed, or if advents put the patient at risk. Any questions on this? I see a question popped up.
How can one improve a 30% How can one prove a 30% improvement in pain in a patient who has been taking opioids for years? Can't discontinue doses to assess.
So you've got an excellent point with that question. Pain relief is very subjective and not objective. So therefore, you have to go by what the patient tells you. And that's the very frustrating point about the VAS, is a lot of times patients are very inconsistent with the scores that they report. I would tell you, we went to the Mankowski scale at our clinic. Has anybody ever heard of the Mankowski scale? Basically, Dr. Mankowski was a child, I believe, psychologist or psychiatrist who treated children with chronic pain. And since children could not comprehend the VAS, or some of them were, nonverbal and unable to report scores, she created a scale of 0 to 10 based off of interactions with the patients that she could verbally record the scores herself. So to put in perspective, a 10 would be the patient is unconscious and unable to communicate due to their pain. A score of 7 would be that patient's in severe pain, but able to speak without being short of breath. I would encourage you to look up that scale, and if you want, I can post that, and you can use it. So a lot of times when we have patients fill out the VAS in our clinic, we'll have them read, or we'll give them the Mankowski scale to read, and then post what it is. So by definition, every individual that comes to our clinic, nobody is above a 7. Because every individual that is there is able to communicate without being short of breath about their pain. And I think once you kind of put that scale in front of people, it kind of puts it more in perspective. Because if you don't have that objectivity, every patient's going to tell you their pain is 10 out of 10. The second thing is function. How do you determine objectivity with function? Well, if you work in a facility where you have access to physical therapists, you could have an initial evaluation with the physical therapist where they put a patient through certain activities and record their score. And then after you initiate the opiate therapy, you could have them redo those objective measures and see if there is an improvement. A lot of times we see this with intrathecal pump therapies, that when we say there's a trial, the patient will see the physical therapist beforehand. They will do a predetermined functional test. They will record what that is. The following day, we will do the pump therapy, and after the pump pump trial is done, the physical therapist will see the patient back and put them through the same paces and see if there's any improvement. So you technically could do the same if you have access to a physical therapist with oral medications as well.
when I was working with Richard Cronin, who was UCLA's pain management director, he would use a 10-centimeter line with no numbers or anything, and they'd just have the patient, swipe where their pain was on that particular day. And in future visits, he'd give them that same line, compare that with where they put it, and literally try to mathematically figure out the percentage of difference. To be able to get to that without using 0 to 10 as a gauge, like you were suggesting.
Yeah. Yeah, it's very, like I said, patient perspective, or, it's very subjective. And so any way you can make it more objective, either by the Mankowski scale for the VAS, or some type of measure with function by a physical therapist would be great. And if you can have documentation of that, that can obviously substantiate for continuing opiates. Any other questions? Any questions on that? Perfect. The next recommendation that the CDC had is before starting and periodically during opiate therapy, providers should discuss with patients known risks and realistic benefits of opiate therapy and patient-provider responsibilities for managing therapy. And the reasoning behind this is that no studies found that evaluate the effectiveness of patient education or opiate therapy plans as risk mitigation strategies. So there's nothing out there to say that you having this conversation is going to make a difference. But what they found by looking at the evidence is they found that that patients lack information about opiates. So basically, a lot of times they don't understand the consequences of being started on these medications. And they also found that providers miss opportunities to effectively communicate about safety, especially regarding these medications. So they want providers to do the following. One, explain that no evidence exists that opiates improve pain or function with long-term use and complete pain relief, and to let the patients know that even though you're starting them on these medications, that complete pain relief is unlikely. So 0 is not the goal on the VAS. They want you to emphasize that improvement in function is a primary goal and that function can improve even when pain persists. So even though the patient still may have pain after initiating the therapy, you need to let them know that that is expected, and that you're looking more at their function and not their improvement in their pain scores.
My favorite phrase is movement is life. With chronic pain, you still need to move.
Correct.
And anything that slows that movement down, which could be opiates, could actually be counterindicated.
Correct. The third thing we want you to discuss with the patient is serious adverse effects. This includes fatal overdose, development of a serious lifelong opioid use disorder. How many people out there actually discuss this adverse event with patients? You guys do? Okay. It's interesting, especially in our clinic, being an interventional pain practice, we talk to patients all the time about, adverse events that can occur with procedures, typically one, infection, bleeding, or possible nerve damage of certain procedures. Even though they're very rare, it's interesting on how many patients decline based off of, even though it can be less than 1%, that they're not going to follow through, that sounds too dangerous. But yet, they will accept an opioid script where the consequence can be death.
Yeah.
And so I try to explain to patients, like, look, so you're unwilling to try this procedure where there is no consequence of death, but yet, on the other hand, you're willing to accept my prescription for these pain medications, which can cause death. And so I try to point out that the decision-making by the patient is not consistent or out of character.
One of the things I also observe is that not many people realize the number one effect, adverse effect you got on the list there is constipation. Opiate-induced constipation is very common and very difficult to deal with. I know that I had a total knee replacement 4 months ago, and when I experienced the opiate-induced constipation, that was probably my major concern.
Yeah,
And I know some docs will automatically prescribe medications for that along with the opiates. Have you had that experience? Or?
Yeah, so the next thing we want is to discuss the common adverse events. And basically, the initial appointment I will discuss with patients constipation, nausea, vomiting, drowsiness, confusion, tolerance, physical dependence, etc. But usually at subsequent visits, once patients are on stable doses, I really don't go over these as much unless the patient raises the issue. But you're right, probably the number one side effect I hear about most is constipation.
And do you have recommendations for medications that they can take?
So basically there's two medications that come to market. Well, let's back up. So usually I'll start with over-the-counter medications. So usually constipation comes down to two things. One, lack of water in the system, or two, lack of gut mobility. So a lot of times I'll recommend Colace. Colace is a stool bulkner, and so I'll recommend patients take over-the-counter Colace, one in the morning and one at night, for hopefully to help them retain water, to make it so the stools are passed. The second thing that I'll recommend is Senecot. Senecot is a gut motility drug. And so typically you tell patients that they want to have a movement in the morning, you tell them to take it before bedtime, or if they want to have a movement at the end of the day, I tell them to take it first thing in the morning, because Senecot will cause gut motility, and usually the result will be a bowel movement 8 hours after taking the pill. So typically those are the medications I'll start out with at first. Second thing I'll talk about is diet, and adding fiber to their diet to hopefully bulk the stool and make it easier for it to pass and retain water.
You know what I found was the best thing for me? Prune juice.
Prune juice?
Prune juice. Just bought it at the store.
Yeah.
It worked wonders. So.
If patients fail, dietary or over-the-counter medication things, then I will recommend that there's two medications out there, and I can remember one off the top of my head. One is Movantik, and the other one, I can't remember now, but I will give patients samples of those drugs and let them try it. And if it seems to help, then I'll give them a prescription next month. Any other questions on that? Okay. CDC also recommends that you advise the patient on the increased risk of opioid use disorder, overdose, and death at higher dosages. And they want you to discuss specifically in that conversation how self-medicating is dangerous. Because a lot of patients aren't going to follow the prescriptions on your bottle, and so they want patients to be aware that any taking medications not as prescribed can lead to these consequences. They also want you to discuss the increased risk of overdose when taken with benzodiazepines, alcohol, or other sedatives. They also want you to discuss with the patient that periodic reassessments to ensure that the opiates are helping to meet goals are done. And this also allows opportunities for you to intervene if they become harmful. They also want you to discuss precautions or how you are going to determine if the patient's at risk. And they want you to discuss openly how you'll check PMPs, do urine drug screens, and openly discuss how naloxone can be used for overdose reversals. How many people out there are actually currently prescribing naloxone with every script that they get for opiates? Is anybody doing this practice commonly?
I prescribe naloxone, but only for my long chronic pain people, the ones that use long acting, but not for short acting.
You just use it for long actings? Okay. And I don't think there's a right or wrong way to do this, but since there is a big push now to give patients naloxone, I have to say that it seemed counterintuitive to me to give naloxone, even though it is recommended. It seems like you're almost promoting bad behavior in a roundabout way. or you're promoting riskier behavior for them to push the limits and try to modify the medications and use them, because at the end, if something does go wrong, they have a way to reverse what took place.
There's a question, if they can't afford over-the-counters, what prescribables are there?
Oh, is this for the constipation?
I'm not sure.
I'm assuming that you're saying if they can't afford over-the-counter medications for constipation, they're saying what medications can be prescribed? Oh, for naloxone?
Yeah, if there's any alternatives.
I do not think there's any alternatives out there for naloxone.
There are a lot of programs now where they're trying to get naloxone to people, right?
Yeah.
But alternative naloxone, I'm not familiar with any other.
Yeah, the programs that I know of that are getting naloxone out there isn't for just the general who wants it. It's specifically for at-risk patients that, like our program for the rural hospitals is to give it to overdose patients if they make it through it at discharge, because they're an absolute at-risk patient.
At risk.
And not so much a pain management patient talking.
Yeah.
You know, can I just say too, on the other side of this, you know, we're talking about naloxone as like the worst case scenario, but I also really appreciate your approach before you prescribe opioids of evaluating the risk. I have a family member that went in, sciatic pain. The doc prescribed opioids, and she has like a huge depression problem. And all I could think was, she's someone that could so easily get addicted. And so I just really appreciate that you guys often, you know, pre-screen them. So it's like, well, is this a high-risk patient? Is this the best thing for the short-term problem?
Correct. And then they also recommend that you have a conversation with the patient if there's any cognitive limitations that would interfere with them managing their own medications. And if there are limitations there, then should you use a caregiver to help co-manage the medication therapy. You also need to make sure that whoever their caregiver isn't going to steal the medications as well, so there has to be some input there. So you should have an open conversation with the patient and the caregiver about how medication should be dispensed. They also recommend that you discuss with them about the risk to family members, which includes the possibility of overdose if you share the medications with them, or if there's an unintentional ingestion. And lastly, they want you to have a discussion with the patient about storage options and safe disposal of unused opiates if they don't use all of the medications. I think I just saw a study yesterday that they said that like 60% of Americans have unused opioids in their house, I believe, from a prior procedure or something they'd had done because they didn't know what to do with them, and so they're just available in the house sitting around. And that's basically all I got today regarding this. Anybody want to have any discussion, comments, questions regarding these recommendations by the CDC?
And how about any of the people who don't have their video turned on? Can't see if you're raising your hand or not, so.
Yeah, make sure to unmute yourself with the icon in the bottom left corner.
So my question is who has time to go through all the educating those patients, the patients on all those checkpoints that they want, and the ability to document that you went through all those things? It is a very time-consuming and tough to document all these things.
From my perspective as a psychologist, I recently read a study that showed that of all the people that are given opiates, only half of them utilize them, and of those who utilize them, the average reduction in pain is the 30% mark that you were talking about. So for me, that take-home message was that pain medications, while they're extremely valuable, and I'm sure glad I had them during my post-operative care, aren't a long-term solution. We need other things.
Correct.
So I would just support that thought and say that the take-home point for me is the bottom line: chronic opioid pain therapy is not effective, and so I need to focus on the other modes of therapy, and in the long run, either taper patients off these medications, refer them to a pain specialist. Sorry.
That's my job. Don't worry about it.
Or you make it clear to my patient that that's the goal. I cannot treat you with these medications long term. Unfortunately, in the meantime, we have to negotiate all these hoops with the insurance companies to try and get them alternative modes of therapy.
Correct.
I know that our chief medical officer's goal is to make those available to our patients, and the powers that be in my organization are working at all levels to try to make that happen, including dealing with the legislature and Medicaid, which I do not envy them in fighting that battle, but hopefully we can affect some changes in that regard. Thanks for your lecture.
Hey, thank you.
Question, is there a breakdown of what best meds for type of pain, i.e. neuropathic pain, bone pain, spasms?
No, I don't think there is a medical evidence or medical literature out there stating which medications are best for what types of pain. I would tell you that usually it is unfortunately a trial and error process. The one thing I'd caution you about medications is muscle relaxants are really a misnomer. There are truly only 3 medications in that classification that actually relax muscles, and one is benzodiazepines, which I would avoid. Long-term use of those can be dangerous and deadly from withdrawals. 2 is tizanidine or Xanaflex, that actually has shown in clinical studies to actually relax muscles. It's usually very sedating, and so a lot of times I'll use it at night time for patients to get sleep and also help with spasms. And the 3rd medication that has actually shown to relax muscles are baclofen, and so a lot of times, that's less sedating. I'll prescribe that during the day. All the other more muscle relaxants like Robaxin, Flexeril, etc., they truly do not relax muscles. And so I caution you, if you think a patient does have muscle spasms that need to be addressed, I would try probably tizanidine or the baclofen. The other medications are just neuromodulators. They're working on the pain pathways at different spots. So you can use those muscle relaxants as a neuromodulator to hopefully alleviate patients' pain. Typically, I tell you, if somebody has like post-herpetic neuralgia, they have a spinal cord injury, they have a pinched nerve, if they truly do have neuropathic pain, then you're probably looking at the anticonvulsants are the best first-line therapy. I don't know if there's any evidence that proves that, but gabapentin, pregabalin, or even duloxetine may be your first line in those patients. Is there another question?
What was the first one you warned against?
Benzodiazepines, Valium as a muscle relaxant, because long-term use of that, it can become physically dependent, and if it's discontinued abruptly, it can be deadly. Any other questions or comments out there? Perfect. Well, thanks, guys. I appreciate it. It's 9 o'clock. We'll call it an end for today, and we'll continue, I believe, on this discussion. Next time, we'll go over the rest of the recommendations. Thanks, everyone. Thanks for tuning in.
Goodbye.
Thank you.